Hello everyone, and welcome to today's webinar, Managing Menopausal Symptoms with Cognitive Behavioral Treatment, presented by Professor Myra Hunter. My name is Anindya, and I will be your moderator for today's event. So before we get started, I would like to cover a few housekeeping items so you know how to participate. You have entered this webinar into listen-only mode. That simply means that your microphone is muted, so we don't pick up any noise from your end. We do welcome and encourage to submit your text questions at the questions panel on your webinar control panel. You can also enter your questions at any time, and we will save them after the Q&A at the end of their presentation. So we are recording today's webinar, and it will be accessible at www.emas-online.org. And at the end of the webinar, you will receive a brief survey, and we appreciate your response. So thank you for joining today, and I would like to introduce you to our presenter, Professor Myra Hunter. Welcome, Professor Myra.
Hello,
Professor
thank you.
Myra. Okay, so the time is yours now.
Thank you. And I'd like to start by thanking EMAS for inviting me to speak today and to present this webinar on managing menopausal symptoms using cognitive behavior therapy. And this is an area I've been studying for many years, both as a clinical psychologist working in hospital settings and as well as an academic psychologist. And I'm currently retired, but like many of us, still working. So I'm going to be talking about CBT. First of all, cognitive behavior therapy for menopausal symptoms and what that looks like. Secondly, I'll talk about clinical trials that we've carried out, answering the question, does it work? And then some sub-analyses we've done to examine who benefits, who doesn't, and how does CBT seem to be working. Excuse me. And finally, to look at the current studies we're doing and how to increase access to cognitive behavior therapy, because this is a question that I'm often asked. Some background then. I mean, myself and my colleagues tend to view the menopause, as many of you will, as a biopsychosocial transition involving biological factors, hormone changes, menopausal symptoms, but also, and importantly, psychological factors, the beliefs about menopause, mood, and social and cultural factors. The social meanings of menopause are still important, and lifestyle, as are lifestyle factors too. And the cognitive behavioral model really maps onto this biopsychosocial model, looking at the impact of psychological factors and psychosocial factors on biological factors and vice versa. So what do we mean by menopausal symptoms? Now, strictly, the specific menopausal symptoms are obviously hot flushes and night sweats. We know, though, that there's lots of evidence that CBT is an effective treatment for anxiety and depression across the age range for both men and women, and is used as a first point of call, first treatment for these problems in many countries. And there's evidence that cognitive behavior therapy is an effective treatment for sleep problems, insomnia, again, for the general population. However, McCurry et al. Have conducted a study recently showing that CBT is effective for sleep problems specifically occurring at the menopause. Now, as we can see on this little diagram, there are often interactions between hot flushes, mood, and sleep. Mood problems and sleep problems can have other causes, psychosocial causes. Midlife is a very stressful time, but these problems interact with hot flushes that are common during the menopause transition. And we know that women often seek help when they have a combination of these symptoms. And so we've developed the specific cognitive behavior therapy for hot flushing and night sweat that also targets stress, mood, and sleep. I'll say a little bit more about this in a moment. So at its most simple, cognitive behavior therapy looks at relationships between physical symptoms, thoughts and beliefs, feelings and behaviors. And this is some of the background research that we're building on to develop the CBT. So we know that general stress and anxiety are associated with more problematic hot flushes, both before and during the menopause transition. And we don't know exactly the cause of hot flushes, but an accepted model is that it's the rate of change of estrogen that lowers the threshold for these symptoms. And there's some evidence also from laboratory studies that stress also lowers the threshold for hot flushes. We've done a lot of work looking at beliefs and behaviours relating to hot flushes, and we've found that negative beliefs about menopause, associating menopause with a abundance of symptoms and problems, and negative beliefs about hot flushes, which I'll describe in a moment, are associated with more problematic hot flushes and night sweats. Research suggests that about 50% of hot flush events can have an identified precipitant or trigger, and these are quite individual to women. And it can be sort of drinking coffee, tea, rushing, having an argument. It's helpful to explore these individually with women, and this gives an opportunity to modify these behaviours if women wish to, and therefore gives a bit more control over the symptoms. And finally, problem rating, or how bothersome the symptoms are. This is the variable that we are generally targeting with CBT because it's associated more with quality of life and help seeking than is frequency alone. So to say a little bit more now about the thoughts and beliefs, what are they, and the behaviours. So we've done a lot of research, qualitative research and quantitative research using factor analysis, and developed the hot flush belief scale and the hot flush behaviour scale to really target the specific cognitions, beliefs and thoughts that are associated with more problematic hot flushes, night sweats. So taking beliefs first, we found that hot flushes in a social context are often associated with thoughts about embarrassment and anxiety, social embarrassment, and these are typically worried about what other people think. Other people are looking at me, other people think I look stupid, or other people know I'm going through the menopause. And I think these beliefs are very common, particularly in the work setting, where women often try and hide their expression of their menopause through hot flushes. And this can lead to more anxiety, actually, the act of trying to hide the symptoms. That's an important one. Secondly, our perceived lack of control over the hot flushes, feeling overwhelmed by the flushes, thinking they'll never end, have no control of them, and feeling rather useless and hopeless about having these symptoms. And thirdly, negative beliefs about sleep and night sweats, and these are very common in general, but particularly when people are woken up at night with night sweats. So two typical sorts of beliefs. One is, if I have night sweats, I'll never get back to sleep again, and worry about that at night keeps you awake. And secondly, worries and thoughts, if I'm woken up, I'll feel terrible the next day and I'll have to cancel meetings, etc., etc. So these sorts of beliefs are unhelpful in terms of what we know about CBT for sleep problems. Moving on now to behaviours. And overall, the avoiding situations was the sort of behaviour that was associated with more problematic symptoms, perhaps not surprisingly. But women would tend to avoid public transport and avoid particularly social situations and maybe certain aspects of the work environment. And a more specific example, actually a subtle example, I was speaking with a woman who worked as a dental receptionist, a lot of contact with the general public, and she would tend to hide her face with her hair when she had a hot flush. But actually this behaviour drew more attention to her and to her face, and I don't think it was terribly helpful. And so avoidance is something which, if there's a lot of avoidance behaviour, it can actually limit women's opportunities to find out if they can manage and to use strategies, and actually can reduce well-being in the longer term. Next, we have a whole range of cooling behaviours, and I think when we studied these, a lot of women use these, and they may be helpful in some individual cases, but as a group, they weren't terribly associated with helpful with problematic or less problematic symptoms. So I wouldn't discourage women from doing it, but they may not be as helpful as we'd hoped. And thirdly, positive behaviours. This was a group of behaviours, generally sort of calming behaviours, accepting the flushes, accepting the menopause, using breathing exercises and using humour as appropriate. So if we put those cognitions and behaviours back into this cognitive behavioural model, we can get a typical vicious cycle. And what I've written examples here is a typical negative vicious cycle. And of course, some women have positive thoughts, positive feelings, and more neutral behaviours. But if we take a typical case here of a woman who's feeling hot, sweating, red face, in a social or work setting, for example, if she thinks, everyone's looking at me, I must look stupid, I can't cope, then she's quite likely to have some of these feelings. And particularly if she's thinking everyone's looking at me, she might feel embarrassed, ashamed and anxious. Or if she's feeling I can't cope, I'm hopeless and useless, she might feel more frustrated and out of control. And having those feelings themselves serves to increase physiological arousal and thus can make the physical symptoms worse, and also can lead to changes in behaviour, avoidance of situations, stopping what she's doing, hiding face, doing less, and importantly too, focusing on herself. We did a small study with various work organisations, asking men, younger men and women, what they might think if a woman had a red face or was looking hot in the office, a colleague. And we found that actually their responses were much more neutral than the women thought that they would be. They would tend to think, oh, maybe she's rushed upstairs, or maybe she's got a cold, or maybe she's gone to the gym. And only a relative minority thought it was due to the menopause at all. So we provide this evidence to help counter some of these quite negative assumptions about what other people think. So the CBT targets these thoughts, feelings and behaviours in order to help people to have calmer reactions to the physical symptoms. And here we've got some examples of less helpful thoughts and more helpful thoughts. And obviously, again, it's individualised. You would elicit the thought that the woman has during the hot flush and then help to find a more helpful thought. And the question you can ask is, what would a friend say to you if you said you had those less helpful thoughts? What would she say to you? She might have a more kindly, neutral thought. I'll leave you to read through those. Okay, so moving on now to how we deliver CBT for hot flushes and what are the main components. So we deliver the CBT in group format, and this is a total of 8 hours, weekly sessions of either 2 hours or 1.5 hours, and between 4 and 6 weekly sessions, and women are in groups of 6 to 12, so it's quite cost effective. And in addition, we have a self-help version of this, which is published in this book, Managing Hot Flushes and Night Sweats, by myself and Melanie Smith with Routledge Publishers in 2014. And this includes exactly the same material, the same strategies, homework, etc. And there are sections in the book where they can write in their thoughts, etc. So it can be individualized, although it's done on their own or with some minimal guidance. And the CBT aims to reduce the problem rating of hot flushes and night sweats. And these are the main elements. Psychoeducation. So this is information and discussion about hot flushes and night sweats with examples from other women, emphasizing the variability of it and looking at menopause in a social context as well, looking at cultural factors, meaning their expectations, the meaning of menopause to them, and countering myths as appropriate. We look at monitoring hot flushes in a diary and finding precipitants, and as I mentioned before, offering to modify, setting goals individually to modifying these if they wish. We're not telling people what to do, we're encouraging people to do what they think might be more helpful. And next, and importantly, we use a breathing exercise. This is a diaphragmatic breathing exercise, which is quite mindful, we look at the attention on the breathing as well as the calm breathing to reduce arousal during a hot flushy night sweat. And we use this for stress and improving well-being, and also for hot flushes and night sweats at night. We use cognitive therapy, looking at cognitions, as I've mentioned, for stress and well-being first, and then once the women get used to the cognitive behavioural approach, we then move on to using this with beliefs about hot flushes and night sweats and menopause. And similarly, we'll focus on behaviours for well-being. Often women spontaneously want to do a bit more exercise for well-being as well, as a well-being goal, but we look at behaviour experiments, particularly, for example, in the workplace, avoiding situations, how can I talk to my manager, things like that, and we get the support of the groups in the group therapy and have examples of this in the self-help book. And then the next session is focusing on night sweats and improving sleep using the CBT approach. We're not aiming really to, we doubt we can stop people waking up necessarily with night sweats, but we help them to have an automatic set of behaviours that they'll do to cool down and calmly go back to bed, and then using CBT for sleep problems to help them to sleep. Now, the last session is very much on reviewing and maintaining changes, and because we're teaching skills here, there's lots of rehearsal, lots of homework, and again, because it's individualised, we help the women to choose what specifically for them has been helpful and what they want to continue to embed into their normal lives. So we look, 3 to 6 months ahead, what barriers there might be to continuing with this work and how they would manage those. Overcome those barriers. Okay, so the treatment is manualised with PowerPoint presentation, CDs, homework sheets. Now, as I've mentioned, it's available in the self-help book, and that there's a manual for health professionals to deliver the groups. So we're moving on now to cognitive therapy for hot flushes. How does it work? And we've got a number of clinical trials here, which I'll just mention, and I'll describe MENOS 1 and 2 trials. These were in more detail. These were both conducted in parallel by our research team and published in 2012. MENOS 1 is with breast cancer patients, and we trialled group CBT, 6 sessions with usual care. And this is published in Lancet Oncology. MENOS 2, using very similar design, is with well women with problematic hot flushes from primary care, referred in from posters in GP practices, and we compared group CBT with self-help CBT with usual care. Again, that's published in Menopause. The EVA trial is conducted in collaboration with colleagues in the Netherlands, in Amsterdam, and this was in several centres, comparing group CBT with exercise in breast cancer patients. Now, I'm including mention of the MAN-CAN study because this was using guided self-help with usual care for men with hot flushes and night sweats associated with prostate cancer treatment. And this because with androgen-reducing treatments, men have hot flushes and night sweats. Now, these are an older cohort with a lot more comorbidity, and some were quite unwell with their prostate cancer as well. It was effective, and if you're interested, you can read more in this paper. Was published in Psycho-Oncology in 2015. And finally here, MENOS at Work is a study that we're currently working on, and we've just published this RCT of unguided self-help CBT in the work context. So I will talk about that. It was actually just published last week in Menopause. So in terms of measuring our outcome measures, as I mentioned, the main measure we're taking is problem rating of hot flushes, but we're also looking at subjective frequency, and we're monitoring sternal skin conductance here to find out how the treatment is working. It's not an ideal measure, but it's good enough, and it gives us some idea of how CBT is impacting on hot flushes. This is used in MENOS 1 and 2 trials. So just to skip through the designs, MENOS 1, we randomized 96 breast cancer patients into CBT usual care and followed up at 9 weeks and 6 months post-randomization. This was funded by Cancer Research UK. Now, these women were on average 54 years of age. About half were premenopausal at diagnosis, so their menopause was precipitated by the breast cancer treatments. And they were on average, on entering the trial, 3 years since their breast cancer diagnosis. So our inclusion criteria were that they'd completed surgery and chemotherapy and radiotherapy, but the majority actually were still taking endocrine treatments such as tamoxifen. So that was within our inclusion criteria. They'd had symptoms for an average 2 years and were having an average 70 hot flushes a week, and they were problematic, 6.3 out of 10. That's moderate to severe problematic symptoms. And a third had had HRT in the past. So for us, it's quite a challenge with the talking therapy because there's a number of physiological elements here for these women that might exacerbate their symptoms. I'll talk about the results together of these 2 trials. So MENOS 2, very similar design, 140 women randomized to group CBT, self-help CBT or control arm. Same follow-ups. And these women, again, from primary care, on average 53 years, quite mixed socioeconomic backgrounds from an inner city area of South London, majority postmenopausal, and they were having on average 63 hot flushes a week, and again around 6, their problem rating was around 6. And these women had had hot flushes for nearly 4 years, which is quite a long time. So in MENOS 2, we compared group CBT delivered by clinical psychologist Melanie Smith in 4 2-hour sessions, and the guided self-help, as mentioned before, was in a booklet. We had 1 initial face-to-face session and then 1 telephone contact, so quite very low on health professional time. So the results of both trials I'm meant to talk about together because they're extremely similar. MENOS 1, the effect of group CBT compared to usual care was significant for reducing problem rating with a high effect size, and we also had improvements in depressed mood, sleep and quality of life, and these improvements were maintained at 6 months. For MENOS 2, we did expect the group CBT to be more effective than the self-help CBT, but we were wrong. They were both equally effective for their impact on hot flush problem rating. And again, the improvements were maintained at 6 months. We had a significant reduction in night sweat frequency, but not hot flushes, and the frequency was highly variable. There were improvements, but they weren't significant for hot flushes. We had improvements in mood and quality of life at 6 weeks for both group and self-help CBT, but the improvements in emotional physical functioning were more long-lasting for group CBT. Nevertheless, for the main outcome variable, the problem rating, they were both equally effective. So you can see here for MENOS 1, the difference with the group CBT for the breast cancer patients and separation of confidence intervals here. And for MENOS 2, and you can see how the lines are extremely similar for self-help and group CBT and how the treatments improvements are maintained. For the EVA trial, and again, this is quite a big multi-center study, comparing exercise with CBT plus exercise and with usual care for premenopausal breast cancer patients. This was group CBT, and we found a significant reduction in problem rating for the CBT alone arm and the CBT plus exercise arm, but not for exercise or usual care alone. The effect sizes were reasonable, a bit lower than for MENOS, but we also found improvements in quality of life. So overall, these results support the MENOS findings. Excuse me. I want to move on now to look at moderators and mediators. Who does it help and how does it work? So Sam Norton and Joe Chilcott, statisticians and health psychologists in our department, helped us with this analysis. So we looked in MENOS 1 at what variables at baseline predicted outcome with the subgroups of women who weren't helped. We found that CBT was effective regardless of age, BMI, time since breast cancer diagnosis, menopausal status at time of diagnosis, or type of cancer treatment. Now, we found that the treatment was significantly greater in women who hadn't had chemotherapy and those with higher levels of psychological distress at baseline. However, even if they did have chemotherapy and had low levels of psychological distress, they still had significant improvement. So it's a matter of degree, but it doesn't contraindicate the CBT for these subgroups. And in MENOS 2, we didn't find any moderators that were significant. So CBT was effective regardless of age, BMI, menopausal status, or psychological distress. So these results suggest that it is sort of broadly applicable for women. Now, to move on to mediators, how does it work? So this analysis looks at process variables. What needs to change to produce a significant outcome? What needs to change during treatment that predicts outcome at follow-up? And we found, perhaps not surprisingly, but it's what we would expect and hope for, that CBT was mainly mediated by changes in beliefs about coping and control, and also beliefs about night sweats and sleep. So these sets of beliefs needed to change in order to have the outcome. There was partial mediation with changes in beliefs in social context, the embarrassment and anxiety, and changes in low mood. That was particularly for the breast cancer patients. So the CBT was doing what it was supposed to do. For the self-help CBT, those who read the book fully and carried out the homework assignments benefited more. Now, just to touch on the physiological measure that I mentioned, whilst we were doing the study, the method of analysing the software was improved to a pattern recognition software. And so we used this to analyse the data and found a significant, small but significant reduction in physiologically measured frequency for CBT for women in MENOS 2, the well women, but not for the breast cancer patients. So this suggests that there might be some impact of the CBT on physiological measures, and it could be, we don't know, but it could be reductions in arousal with the calming effect of the treatments. And finally, in terms of feedback, we did qualitative interviews at the end of the treatments following the last follow-up, and Janet Balabanovic conducted these studies. She was an independent, she wasn't involved in the main study. And the result, we wanted to ask women themselves, what did they think changed? And because, I mean, it was interesting, they felt, oh, they didn't really know how it changed, how the treatments worked. But they just felt that they didn't notice them so much, they didn't bother them so much, might still have them, but you know, they didn't notice them. And for others, they did reduce in frequency as well. So the main themes were that they reported improved coping using information, calm breathing, and CBT strategies, and that this was associated with a restored sense of control. They mentioned acceptance quite a lot, acceptance of hot flushes, acceptance of menopause and of themselves, and this seemed to be fairly central to the improved experience, staying with the hot flush symptoms rather than fighting them or avoiding them. And a large number of the women also reported experiencing beneficial changes which extended beyond their hot flush symptoms. They used the CBT strategies in their lives in general. Okay, so I want to move on now to look at current studies and the section on increasing access to CBT. Now, we've continued a productive collaboration with Neil Aronson's group in Amsterdam, in the Netherlands, and moved on to looking at EVA Online, a trial of computerized CBT for breast cancer patients. And this should be reporting, I think, towards the end of this year or early next year. Secondly, and again with breast cancer patients, is a multi-centre trial currently in process in the UK. And in MENOS 4, we're training breast cancer nurses who have no past experience of CBT to deliver group CBT for breast cancer patients. This is using the manual. This is led by Debbie Fenlon, funded by Breast Cancer Now. And I did the training, and it was very interesting, and I think I feel very positive about this. If it does work, we can then hopefully roll out the treatments in these services. Now, next, the next study is a small community project, but I think it's interesting, and this is something that can be set up in a number of different settings. And this is a project led by Eileen Bellett and colleagues called by charity Hands Inc. in Hackney in East London. And she set up a 12-week group, a community group for Black and ethnic minority women who might not typically access services. And she included the self-help program within this broader group that also looked at sexual functioning, lifestyle, and embraced cultural aspects too. And we've written a small description of this in Post-Reproductive Health. I think that's just come out. So I think you can use the CBT in workshop formats and in adapt it also using the manual for group CBT. And finally, we're currently working, as I mentioned, on menopause in the workplace with 2 types of intervention to improve women's experience. I'll talk a little bit more about this now. So this has been a 3-year study funded by Wellbeing of Women, a charity based in London, with Claire Hardy, the lead researcher on the study, and Sam Norton, a statistician, and Professor Amanda Griffiths from Nottingham University, and myself, based at King's College London. So 2 studies. Now, our overall aim is to improve the quality of life for menopausal women in the workplace. So the first study is a trial of unguided self-help CBT with 8 organisations, some public sector, some private sector across the UK, for working women with problematic hot flushes. And it's important to emphasise not a clinical context, it's a work context. So we linked with interested parties in human resources, occupational health, and my colleagues Claire Hardy and Amanda Griffiths are occupational psychologists. I'm a clinical health psychologist. So the combination was very helpful and rewarding to work on this study. The protocol papers published, and we've published the RCT last week, and I'll talk about that in a moment. But the other part of the study is more developmental. We're developing, evaluating an online training intervention for employers and managers aiming to increase awareness about menopause in the workplace. So, because I think it needs a 2-pronged attack, really, helping women who have problems, but also helping to create menopause-friendly environments in the workplace. Because whilst hot flushes and night sweats are problematic for women, the workplace attitudes, ability to talk about menopause, and certain physical aspects of the workplace can actually exacerbate the experience for women at work. So the trial, the RCT, we randomised 124 women to self-help CBT, unguided. They literally got a booklet with a no treatment control, and followed them up as before, 6 weeks post-treatment and 6 months post-randomisation. Our primary outcome again was how problematic the symptoms were, and self-help CBT significantly reduced hot flush night sweat problem rating at 6 weeks and at the final follow-up compared to controls. These were highly significant findings. In addition, in terms of our secondary outcomes, we looked at other individual factors to do with hot flushes, mood, etc., but also we looked at work variables, work-related variables. So we found that hot flush frequency improved, as did work and social adjustment. We used the work and social adjustment scale. Sleep improved using the revised Women's Health Questionnaire and the Quality of Life Pittsburgh scale. Quality of sleep Pittsburgh scale item. Menopause beliefs and hot flush beliefs and behaviours improved at 6 and 20 weeks. And we also had improvements in well-being and somatic symptoms on the revised Women's Health Questionnaire at 20 weeks compared to control. So lots of additional improvements, as well as the hot flushes and night sweats. Moving on to the work outcomes, we looked at performance, absence, turnover intention, that is, intention to leave the organisation, and presenteeism. And we found significant changes in presenteeism at 20 weeks. Let me explain this. Presenteeism was measured by the Stanford Presenteeism Scale. So if you have high presenteeism, it means you're working, feeling unwell, and your symptoms are interfering, impairing your work. So we found significant reduction in presenteeism. So these women were having the menopausal symptoms, but not experiencing work impairment. So it's consistent with coping better with the symptoms, isn't it? Interestingly, at baseline, the performance was 80% of the women felt that they were performing very well or excellently at their work. So there wasn't much room to change their performance. So it wasn't as though the symptoms were affecting their performance. And similarly, the absence ratings, this was taking any form of absence, whether they came to work late, left early, or took half or full days. And we did find some improvements in that, but they weren't significant. So to our knowledge, this is the first study to develop and evaluate a specific intervention for helping women to manage these symptoms in the workplace. And the results suggest that this is a effective, low-intensity, non-medical intervention for problematic symptoms that has additional effects on sleep, well-being, work and social adjustment, and on presenteeism. And so I think the study has implications for employers and other stakeholders who have a responsibility to provide helpful resources for working women. And I should emphasise evidence-based resources. There's a lot of activity in this area, and I think we need to stop and really evaluate what we're doing in terms of interventions in the workplace. So a couple more slides. So how do we roll out CBT? I've mentioned the self-help book. I've mentioned the manual for health professionals. And in clinics, the self-help book can be given out to women. You can offer a telephone help supportive session if you wish, just to encourage the behaviour changes. But the self-help book in itself is helpful. We're continuing to work with organisations to further evaluate and implement our work. And Claire Hardy is leading on that at the moment, and that's her email if anyone's interested to contact her about these studies, claire@womenshealthatwork.org. And we're collaborating with the British Menopause Society in two ways. Firstly, Melanie Smith and Janet Balabanovich are running a training course, and this is using the manual for group CBT for health professionals who may have no CBT background at all, as well as those who have, but this is particularly targeted to provide additional training for health professionals who want to run groups, for example, in primary care or in menopause clinics. And this is happening in Manchester, in UK, in March this year. And it's not too late to apply if you're interested. Just look at the British Menopause Society website. And similarly, in collaboration with the British Menopause Society, Melanie and I have produced two fact sheets, one for information for health professionals and one for women. These have been reproduced in Post-Reproductive Health, so can be accessed there. But the fact sheet for women, which you can, which women can have, there's free access to this on the Women's Health Concern website. If you just Google Women's Health Concern fact sheet cognitive behaviour therapy, and this gives quite a detailed outline of cognitive behaviour therapy, and maybe the place to start for someone who's got mild to moderate symptoms if they want to know more about it. So to conclude, CBT seems to be a viable non-medical option for menopausal symptoms and is effective in clinical and work settings. It's recommended by the North American Menopause Society and in a recent BMJ clinical practice paper. And it can be offered in a range of methods with varying intensity, from fact sheets, self-help books, workshops, one-to-one and group CBT, and we're continuing to work on increasing access and training other health professionals and evaluating the impact of this work. Thank you for listening.
All right, thank you so much, Professor Myra, for the presentation. It was really interesting. For the audience, we have now a few polls that will need to be answered by you. I will launch the first polls. So a key element of cognitive behavior therapy for menopausal symptoms is, what is your answer? And if also, I would like to remind you, if you have any questions for Professor Myra, please keep it typing on the question sections. Okay, I will give you a few more seconds to answer this poll. All right, now I'm sharing it. So, Professor Myra, are you there?
Yes, that's exactly, that's the right answer.
Okay, so let's go to the next poll. I'm still encouraging everyone to type their questions, okay? Okay, so the second poll now. CBT helps women to manage hot flushes and night sweats. You can start to click the answer. I'll give you a few more seconds. All right. So, Professor Myra, 7% answers only when delivered in group formats, and 93% answers when delivered in both groups and self-help formats. What do you think?
Oh yes, well, the 93% are correct.
All right. So, okay, I will launch the third and last poll. Clinical trials have shown that CBT for hot flushes and night sweats. Please select one of the answers. I'll give you a few more seconds to answer. All right, let's see how. Okay, 100% says
Yes, well,
it has.
Well done, everyone. Thank you.
Well done, everyone. So I'm still encouraging everyone, if there's any question. Okay, so we have a question from AK Rising. How does HRT figure in?
How does HRT figure?
And yeah.
Okay, well, this is a sort of an additional treatment, a non-medical option. So I think women, I think it's important to, obviously HRT is an effective treatment for these symptoms, but I think it's important to have evidence-based alternatives for those women for whom it's contraindicated or who don't wish to use a medical treatment. So it's an option. Now, I think one area where it could be used is if people want to come off HRT and they want some strategies to help them to manage hot flushes that might occur when they're coming off hormone replacement therapy.
Okay. Okay, so the next question is from Rebecca Glasser. The question is there a role for CBT in addition to hormone therapy?
That's a really good question, and we haven't done that sort of study. I imagine if someone's taking hormone replacement therapy, and if they're still having some symptoms that are causing them bother, then they could add CBT to that. I think it would be an interesting trial to use both. When I was first studying this, I did an exploratory trial where people were taking CBT or HRT, and I think HRT worked slightly more quickly, but CBT had longer, was maintained the improvements for longer. But I think it could be interesting to use both. But obviously, if HRT works and just gets rid of the hot flushes altogether, then you wouldn't necessarily need CBT, unless you want it for sleep or these other problems. I mean, I think I'm a big believer, present the evidence and really help the woman should be choosing which treatment or combination that she wants.
All right, thank you, Professor Myra. Next question is from Ailke Rising again. Were all the women in the trials non-medicated?
Why are they non-medicated?
Were all the women in the trials non-medicated?
Oh, I see. Were they? Okay. So the breast cancer patients obviously were taking medication, endocrine therapies for their breast cancer, but other than that, they usually weren't taking many treatments for their hot flushes. In terms of our inclusion criteria, they could be taking some treatments. I mean, 1 or 2 were taking HRT but still having symptoms, or they might be taking a non-hormonal treatment for hot flushes, a small proportion, but they were still having symptoms. So our criteria were, you're still having these problematic symptoms, but most weren't. Most had tried things that didn't help them particularly, or they didn't want to take anything medical. But good question.
Right.
Thank you.
We have one more last question. It's from Anne Mears. The question is there any connection between CBT and motivational interviewing?
Well, to some extent, I think, yes. I mean, I've used both in a broader clinical setting, and I think both use cognitive strategies and ways of interviewing, and I suppose there's similarities in the way we would elicit from the patients their thoughts and beliefs rather than telling them what to do. So in motivational interviewing, we very much work with eliciting from patients. We help the patients to come to their own conclusions. So I think in that way there are parallels. Yes.
Okay, I think that's all of the questions. Professor Myra, do you have anything else to share before we wrap up?
Not especially, just to thank you all for listening, and for those who will be listening once this goes online. And thank you again to EMAS for hosting this webinar.
All right. Thank you so much. So this concludes the presentation and the webinar. Thank you so much for your wonderful presentation, Professor Myra, and all the audience for being here today. Just a quick reminder, you will receive a brief survey that pop up when I end the webinar, and we appreciate your response. Thank you, everyone, and have a great rest of the day.